support the fathers. Oh, there we go. Thank you. Just a heads up, we are recording this presentation. Um, to be able to support the fathers in Washington to me is deeply meaningful. My parents had me in college, and although I was primarily raised by my single mom, my dad and my stepdad profoundly changed my life, my academic direction, and how I value family and relationships. I saw them proactively choose our relationship, their role as fathers, actively bucking against the toxic systems and relationships that stood to get in their way. If not for that persistence, I wouldn't be here today as an allied professional, holding systems accountable to seeing and valuing the role of men and fathers in our families and communities. We are excited to be able to kick off the Fatherhood Council Provider Learning Series today. The focus of our presentation will be on men's sexual and reproductive health care and access in Washington. And as healthcare professionals, we actively try to use gender expansive language, but for today's content focus, we will be using the terms male and men. I truly appreciate all of you who submitted questions through the registration process. It really showed the range of your interest. Our content today is already quite robust, so we don't want to try to stray too far out of scope, but we'll be happy to participate in any future sessions where other topics like, say, doulas or confidentiality truly deserve more time and attention. And so with that, I am going to turn it over to Kai and Abby with Implementing Contraception Access Now to introduce themselves.
Great. Thank you, Andrea. It's a pleasure to be with you all today. My name is Abby Shirk. I'm ICANN State Policy Director. Stands for Implementing Contraceptive Access Now. We are a small but mighty national nonprofit organization really dedicating to implementing Medicaid family planning programs. And in Washington, that's your family planning only program, FPO. And so we partner behind the scenes with agencies, Medicaid, Department of Health, other state agencies to really maximize these programs. We partner with providers to talk about training and implementation at the health center level. And then we really think about patients and members and community members who deserve to have access and knowledge and be able to take opportunity of the resources that are available to them. With that, I'll hand it to Kai.
Great. I think there's a next slide of intros, right?
Yeah, I think we have a couple more fatherhood slides, and we're just doing a quick intro now.
Gotcha. Okay, great. Hi, everybody. Good afternoon. Or I guess it's quite not noon there. I'm here in Chicago time, Central Time. My name is Kai, like Cobra Kai or Kai Rizdale, she, hers, my pronoun. I'm the principal and co-founder of Implementing Contraceptive Access Now and have a long history of working both in public health and in health center operations and practicing as also a certified nurse midwife doing deliveries on the weekends. I'm going to go ahead and pass it over to Linka.
Hi, my name is Lenka Czech. I'm a certified nurse midwife. Right now, I work in a small local health jurisdiction health department in Great Harbor. We have a program, Reproductive and Sexual Health, where I am. My background comes from Colorado. Most of my I practice for underserved community, rural, mountain, immigrants, speaking different languages. And I'm happy to be here today. Anybody else?
I think it's back to Andrea, if you want to walk us through.
Okay,
Yeah.
back to
I think maybe folks might be familiar with these slides, but for fathers and parenting, these are some of the value slides around the Fatherhood Council. So we know that child and family well-being improve when fathers are positively engaged in their children's lives. Fathers play a unique and important role in children's development. Fathers should have support and resources to become the fathers they aspire to be. And these are some group norms for the council and the provider learning series. I'll let folks read these here. We'll just take 1 minute. Okay, and go ahead and move on to the next slide. And we have moved through our introductions. All right, we'll turn it over to Kai.
Great. I'm just going to do a quick overview and then I'm going to hand it up to Kai. But we're so grateful you could join us today for this learning series. We have an ambitious agenda today for you. We're really going to do a men's and sexual and reproductive health care 101 at a high level. What are sort of expectations and norms and best practices around health needs for men and male identifying individuals? And I think folks often have some awareness of STI care, vasectomy, but we're going to just dive in a little bit to really make sure you know myths from facts and just really understand the basics of men's health. Lincoln's going to just share a little bit more about what men's health visits look like in Washington, her experience as a Washington health provider, and just maybe some tips on how to have a conversation and introduce the concept of men's health and men's health needs when you work with either your patients, fathers, or peers in your community. And then finally, Andrea is going to highlight coverage and access, give an overview of Apple Health and Washington's Family Planning Only program. Because we know men's health is so important, we really want to make sure you leave here today knowing what it is, how to talk about it, and where your fathers and patients and clients can access care and coverage. And because this is incredibly ambitious to do in 1 hour, we put together a resource toolkit. We know that we're going to cover sort of high level information here today, but we think it's great for you to be able to dive in on where your interests most aligns later on. So a resource toolkit will be shared out via email at the end of our presentation, just so you can really explore these resources further, have the opportunity to review them, and share them with the communities that you work with. And with that, I'll hand it to Kai.
Great. All right. So this is just sort of a 101 um, in terms of what we think about sexual health, sexual and reproductive health. Sometimes you'll see me use the acronym SRH, and please feel free if I do throw an acronym in there, go ahead and put it in the chat. I'll do my best. We love to do that as healthcare providers and in public health. And so these are our three basic objectives. We're going to look at some of the most common barriers and opportunities to support men in engaging in sexual and reproductive health care. Number two, we really want to identify what did we mean when we say sexual and reproductive health care services, commonly used by men. We're going to focus a little bit about STI and HIV prevention, specifically with PrEP, and then also talk about the family planning options, which are limited, and that's part of the problem. But really focusing on, aside from condoms, which most people are very well aware of, withdrawal method, which of course requires also participation from another partner, but vasectomy services, which is a rather underused service, which we'll talk about. And then look at some myths, in fact, specifically about vasectomies, because I think we see a lot of perpetuation and continued misconceptions, especially with social media around vasectomy. Next slide, please. So just taking a step back, where are our barriers? Um, I want to kind of, in 2010, I was running, so about 15 years ago, I was running operations for about 17 family planning clinics. And we were seeing at that point women only. And time again, I would have patients come in and say, if they had, let's say, a positive chlamydia or gonorrhea, we would talk about making sure their partners are treated. Um, in Washington, there is expedited partner therapy where someone can get treated even without being seen by the provider. So just note that. That's for chlamydia, gonorrhea, and trichomonas. But the point was, a lot of times patients were saying, well, where can my partner come in? Not just for chlamydia, gonorrhea, trichomonas, right? Or how can I get my partner in to be seen? Because I think, he would have some questions. Or I would love for my partner to think about family planning, and we've decided vasectomy is the best option. Where can we go? And so we really realized there was not many good options, especially for men. And I'm going to focus on men with LEO resources, so perhaps eligible or covered by a Medicaid coverage. So having this absence of a clear entry point for men is very real. And then, of course, when we think about some of these buckets, structural changes, structural barriers, oftentimes we think about sexual and reproductive health as a woman's health issue. I already talked about the lack of male services, meaning there's not that many birth control options. We can talk a little bit about the new ones coming up, but also, there's lack of male providers in sexual reproductive health. Even when you think about sexual reproductive health for OBGYNs, which is one of their specialties, right? Today, we're seeing about 85% females coming into it. And then when we think about nurse midwives, whether myself or Linka, it's about 98%, 99% female. And then when you think about nurse practitioners in general, that's about 85%. So, it also can be a reason why men may less likely see healthcare in sexual reproductive health because there's less male providers. And you can see some of the social culturals. I think everyone can think about, the different roles around masculinity. They often don't seek care until it's emergency. Trying to be proactive, preventative may not feel like it's part of a cultural norm. And then also individual, of course. I'm going to share some data about are people getting educated? Yes, this is a fatherhood council, but we know that starts from youth and the first time of sexual debut or thinking about sexual health, thinking about, STI risk. Are there ways that we're, systematically educating them? And then there's always the stigma that comes with it. So we're not going to go through each of these for the interest of time, but this gives you a sense of what are the multiple levels of barriers that men may be facing. Next slide, please. Oh, this is our assumptions. I think we see this quite common when we think that it's normal for women to come seek sexual health services, right? But it's so important that we also take time to be asking men these questions. The idea that sex means the same thing to everyone. I'm going to show a slide coming up that talks about, how do we talk about that? But really, it's someone may say they're not having sex. I think about a patient of mine, quite commonly with our youth, but they were having anal sex, but they were thinking sex only in terms of, risk of pregnancy. Assuming that, oh, everyone knows what a condom. I think I said that at the beginning, right? Everyone knows what a condom is, but are you using it correctly and consistently? Um, Age is also a very much common way that we assume if someone is older, perhaps less mobile, perhaps with any disabilities, that they may not be sexually active. So, really avoiding assumptions there. And then, of course, sexual behavior is static through life. Oftentimes we think, oh, well, we've talked about it. They said they're not sexually active. Things may change, right? 3 months, 6 months, or 3 years, 6 years. But the point is, we have to really be focused on regularly and routinely screening for their contraceptive needs and desires at each encounter and not just assume, oh, we've asked once before and that must be where they're at. We also have assumptions around people who may be having same-sex partners and always assuming that that's the only case and they're not at risk, right? When we actually look at some of the data, especially around women with only female partners who identify as being lesbians, they actually do have a higher rate of unplanned and mistimed pregnancies. And then monogamy, that's also very common where we assume you know your patients, you know their partner, but they may have other type of dynamics. And so not making assumptions and of course not making judgments. So they feel open to talk to you about it. Next slide, please. Um, so I want to, I know we're talking about kind of these assumptions, but I also want for this group to think about whatever role you're in. Are there ways that we can make sure that young males are really, from the beginning, when they are engaging in healthcare, are being screened for their sexual and reproductive health care? And are there ways that your health center or the health entities that you work with could be doing a better job to really make sure that young males are included and not as an afterthought? I wanted to bring up some YRBS data. I don't know if you guys are familiar with the youth risk behavioral surveys. It's basically large systems, often school systems, take surveys. And Washington, the one I last found, and Andrew, you might correct me if I'm wrong, but was from 2021. But it's reported that 28% of Washington high school students reported ever having sexual intercourse, which is actually slightly lower than from over a decade ago. And of those that were sexually active, about 53% reported using condoms at last sexual intercourse. And then of those, and this wasn't just males, 25% reported using birth control pills or some kind of hormonal method. And then there was 11% who actually reported using both a hormonal method as well as condoms. So I do think, there's some of the data is impressive in terms of opportunities. So when we're looking at screening for sexual activity in high risk, I do think have to be sure that there is a safe space for people to be talking about it. Most pediatricians at community health centers are saying, I want to have that private one-on-one time with the patient. If health centers don't have policies in place for this, this should be implemented and instituted so that pediatricians, people who see young adolescents, are regular saying, I want some private time with the person. These you can see some of the topics here in these boxes of what you might be discussing with them. According to American Academy of Pediatrics, they often use the HEADS is the acronym HEADSS. Basically, it's assessment of psychosocial screenings that every adolescent male should be asked about. The HEADS acronym, and you don't need to remember, you can just Google this, it comes pretty quickly, comes up, but it's asking about your home life, asking about education or employment, if they work, asking about activities, what they like to do, what to do with their friends, asking about drugs. The S is sexuality. There's several S's. S, sexuality. Second S is safety. And the third S is about suicide. But that, should be core part of when you're looking at a quality care for pediatricians. They should be employing the heads ass with every well male exam. I'm sorry. So used to seeing females. Also a great way to really hook in young adolescent males is thinking about during their sports physical, or oftentimes we may be seeing males for acne follow-up. And then I wanted to mention that, it's important that we normalize that conversation. If any of you guys are seeing young men are thinking about how do we talk about it, I know Linka's going to talk a little bit about it, but when I talk to a lot of my pediatrician friends, I work at a large community health center, the common ways to kind of normalize the conversation would start with, I talk to all teens about this, right? Or I want to make sure that that I'm here to talk to you about this. Many young people are curious or experiment with kind of as openers. That way it feels very, doesn't feel personal or they don't feel offended, I think is what we want to be sure we're really focusing on. Next slide, please. I know I have about 5 minutes left. Okay, so, when we're screening for STIs, this comes directly from CDC. And they talk about the 5 Ps. Oftentimes there might be a 6P for pleasure. And I know, Linka, you had mentioned there might be a 6P sometimes when we think about pain with intercourse when you're screening for sexual and reproductive health. But you can see the first P is about partners. Again, not making assumptions that they may only have one partner or the type of partner they may have, right? The practices, what kind of sexual contact are they having? What body parts are involved? Because we know clinically now we are testing for different sites, not just vaginal or anal. It could be actual pharyngeal as well, right? Protection from STIs. We continue to say that condoms are the only way to protect or minimize the risk of STIs. We're going to talk a little about PrEP in a second. And then a past history. We often know that a past recent history in the last 3 to 6 months might open up a conversation to talk more about other preventative measures and what we say pan STIs, looking at testing for all the other STIs. And then this last one is about pregnancy intention. This is where we really think about how birth control and STI should go hand in hand, and why engaging males early on or throughout their lifespan to really think about how they can be part of the conversation when we think about contraception. The question that we often use in clinic is, do you think you like to have children or more children at some point? Asking that question, you can think, oh, that seems to be applicable to all ages and all genders, right? Do you think you like to have children or more children at some point? Um, this question then is often followed by, if you can all picture your adolescent, whether you have a client, a young male in your life, um, or it's one of your patients, right? They often giggle when I say this. But then they say, oh yeah, maybe I want kids, but not anytime soon. And so that's where it's important to get that values clarification and for me not to assume what not anytime soon means. Then my next question may be, when do you think that might be? And if they say not anytime soon, what does that mean? Right? Some means not anytime soon, meaning not in the next 6 months. Other people are saying not for the next 10 years. So really important to get that clarification. And then the uh, second part of this is, okay, so you're saying you're not wanting to get pregnant anytime soon. How important is it to you that you don't get your partner pregnant or to prevent pregnancy? Again, that brings in the social cultural norms. And there may be families that say, none of our pregnancies were planned and we were perfectly happy with that. They may have religious values that say if that was, the plan, that's okay. So really that would help guide our conversation around pregnancy prevention. And then the options that you would present to the male or their partner, are having them discuss with their partners at home if you're only seeing the male that day. Next slide, please. Okay, let's pull up a poll really quick before I actually do the slide. I'm sorry. It's a very simple, easy poll about PrEP, and I think it's coming up. There it is. So you can see the question, how familiar are you with PrEP, pre-exposure prophylaxis, as a prevention tool for the fathers you work with? So go ahead and if everyone can just hit your radio button, either you've never heard of PrEP, which is perfectly fine, or you've heard of it, but you don't know much about it, or you're somewhat familiar with it and have mentioned it to clients if applicable, or you regularly discuss PrEP with clients and fathers as part of your work or in your community. Hopefully you can all see that.
Yeah.
Great.
We have about 75% participated, so we'll just give it another couple seconds if folks want to
Perfect.
enter their last.
You let me know and you can just kind of, because I can't see that part
Sure.
or not on my current screen right now.
Yeah, Marilyn, I think we can end the poll and then it should show the results.
Okay. Thank you guys. I would say this is kind of what I expected, where, many of us may have heard about it, but not really sure what it is and who it's for. Or you may be hearing about the first time. So I'm glad maybe if that's one of our key takeaways for today's talk, amazing. So thank you for doing that. So what is PrEP and PEP? I just want to note that you may hear those terms together. PEP is actually different in that is post-exposure prophylaxis, which is not necessarily a tool that we use regularly as much as used for someone when they need it as an emergency. If you possibly had a single episode, such as a broken condom, and you knew that person is possibly HIV positive or at risk of it, or maybe needle sharing, or you had like a stick at a hospital or you work in an emergency room, what have you. So PEP is different. It's post-exposure prophylaxis, and that's used where you try to take some medication for up to 28 days, and you try to do it as soon as possible, ideally within 3 days if you had an incident. Okay, versus PrEP is pre-exposure prophylactics. Basically, it's a medicine where you're going to have to take it like a chronic other meds to greatly reduce your exposure to HIV. So you have to be HIV negative, and you may have a partner that is HIV positive, or you may have a partner that you don't know, or you may be IV drug use and you don't know their statics, and that's when you would take this medicine. It can be in a form of a daily pill, just like popping a vitamin every day. You take it every single day. There are shots now as well, where you can take it every 2 months, and even more recently, as of last year, shots every 6 months. So it is a pretty impressive way because you can see it is 99% effective at preventing HIV when you're concerned about risk of transmission through sex. When it's through IV drug use, it's more about 70 to 80% effective. But pretty amazing that now we have medication to prevent HIV. And so important that we make it part of the conversation with every time you're routinely screening someone for STI, whether it's just chlamydia and gonorrhea. Did you know we have PrEP, right? Many times your patient's going to say, I don't need it. But guess what? The more we talk about it, A, reduces stigma, but B, people are aware of it and they can talk to their friends and their partners about it. We currently think about 1.1 million Americans can benefit from PrEP. But we only have about 150,000 people who have actually been prescribed PrEP. So lots of room for improvement and opportunity to learn more about this. And we also know of the 44% of people who could benefit from PrEP are often our African American counterparts, but only about 1% of people who are using it are African Americans. So again, when we're looking at health disparities, important that we really think about are we doing our job to make sure that this is readily accessible, and also how it's covered, which we'll talk a little bit about as well later on. Next slide, please. I just want to take a small note to note that, PrEP should be something that's in the primary care setting, whether you're with your pediatrician, your internal medicine. It doesn't have to be something that's a specialty clinic. Especially community health centers, they should be regularly talking about it and offering it and starting it. It is not for gay men only. Of course, that's where we see the largest risk of HIV and new diagnosis, but we're also seeing it in heterosexual women, especially in Black heterosexual women over 40 years old, where we're seeing new diagnosis of. That's why it's so important. We're kind of routinely mentioning it and not assuming this is not my population, or I don't work in a population with gay men only. I think most important, if anyone ever brings it up and says they want it, we go ahead and prescribe it versus asking them, like, are you really at risk? If someone is saying, I'm interested in PrEP, we should be starting them on it, regardless of sexual orientation or what they've told you about their relationship status. I think that's the key point here. Okay, next slide. I'm going to go quickly through vasectomies. Vasectomies, it is a permanent contraceptive option for men. For now, that is really the only method we have aside from condoms and aside from a withdrawal. There is probably in the next 5 years, I just like to bring this up, hopefully a pill that will come up. There's in clinical trials right now that can actually stop the sperm production and doesn't change the ejaculation or libido. And there will also, aside from a pill, a daily gel that someone could apply to their shoulders. Again, that halts sperm production. And then two that are kind of further out along the road is really thinking about ways to occlude the vas deferens, so where sperm comes through, an injection of a gel that actually can cause occlusion so sperm can't come through. So that's down the line, and I bring that up because I think people are often interested in saying, why don't we have other options? So I want to remind folks that vasectomy is still a great option. It is the most common option in the United States right now, currently used by primarily people with private insurance. We see it more in white males, about 3 times more, and higher socioeconomic status. It is a procedure that is permanent. I always like to remind people that, even though you may see billboards that say you can reverse it, it's often complex and often costs a lot of money. Often people think you maybe need to be out for a long time. It's a quick procedure. Actual procedures, 15, 30 minutes at the office. You may take about up to that day off and maybe the next day, but really depends on your occupation. But most people, you're not missing a lot of work at all. It's not something that means, you're getting waylaid with a lot of downtime. Again, really important, it doesn't affect a man's ability to perform sexually or achieve orgasms. That's been shown, and lots of anecdotes from many men who've had it and are very happy with it. They actually say sex may actually be even improved because they don't have the risk or anxiety of possibly getting someone pregnant. Nothing's 100%, but it's pretty good, 99.7%. And the beauty of here is in Washington, Apple Health fully covers vasectomies, and so I think it's something we need to be talking about more and providing education in our toolkit. We also have some more information and flyers about it. I am over my time, so I think that was my last slide.
Great, thanks, Guy. Linka, I'll hand it off to you, and I'm monitoring the chat, and we'll just raise questions as we go. And like I said, I encourage folks to leave questions in for our conversation at the end. But thank you, Karen, for just celebrating all the progress we've made around AIDS and HIV. And so thanks for that note. Linka, I'll hand it off to you.
Awesome. Thank you. So this is a picture that I just wanted to give you more, imagination if you've never, or more concrete where we're from, where I'm standing right now. That's a view on the Grays Harbor County and the Chehalis River and the port, and Aberdeen in the back that can be seen at our hospital as well. Just wanted to share. And a little about Grays Harbor County. We have about 77,000 people, and in the main two towns, Aberdeen and Hoquiam, about 25,000. And so most of the people actually live rural, and it's quite dispersed. So it's sometimes really hard to reach all of them. We are very small clinic. I am the only provider here. We see about 1,000 visits a year. Around 70% are Medicaid, and then something that we'll look at as well is 40% Hispanic and 30% Spanish speaking only. I like to differentiate it because it's a different culture. We speak differently to them and explain. It's a little different care because it's a lot of navigation of the medical system as well. And our ratio male to female, I think it depends. We see about 7 to 10% of male and 93% of female. It varies by year. When we look at the Title 10 data, it's about 12%. Next. Awesome. And then I wanted to kind of find some data to support what I'm seeing in the practice. I see that we see less men, right? 10% and 90% than females for their well exam, reproductive and sexual health exams and care. When I look up the CDC National Center for Health Statistics for 2025, it is a reflection of the US data. But as a well exam, only 75% of male had them compared to 85 female. And I also wanted to see like how many have a primary care provider or a usual place of care, and about 85% men and 92% female. So I think that we can see that the data supports what I see in the clinic. We see much less men than women for care in general. And I think that what's important here is to show that not only as a rural place, we really need to address primary care, reproductive sexual health, and mental health care during the same visit to really offer a holistic care, holistic medical care. Next slide, please. Oh, sorry. And then the previous, actually, I just, a primary care to patient ratio in Washington, it's 1 to 1,300, and in Grays Harbor is the double. So we have half less provider per patient. So that's even more important to really provide this broad holistic care. I thought that's just important to know. Sorry, I went back. Next slide, please. So part of the primary care that we do for every male who come, typically the reason why they make an appointment, it's an STI screen, or they have some type of symptoms and they don't know where to go, and so they're thinking we'll come to the public health and hopefully they'll help us to figure it out what to do. But what we do take blood pressure. We also talk about family history, their personal history. Are they symptomatic? What is the normal? If it's abnormal, how do they take it correctly? How do they measure it? We talk about lifestyle changes as well to help them and to kind of start, the care in order to improve their high blood pressure. We can also, when we talk about lifestyle, we talk about diet and exercise, caffeine as well, and kind of thinking about what are the limits, where they can improve. And another screen could be a diabetes. Sometimes we see patients that are super high, uncontrolled diabetes. Maybe it's either undiagnosed, or they know and they just don't go and see a provider. So this is just a reminder to them that, hey, you could die of this, and this is the importance. I really want you to follow up with the primary or urgent care or ER. We talk about vaping, tobacco, cannabis, smoking, and then we have different resources for all of them. If they're ready to quit, we talk about QuitLine, which is a free resource that's really available in every state. We talk about a plan to quit. How do they make it? What are their triggers? I offer medications. Do you want medications? Are you interested at all? We talk about support as well to help them quit whatever product they're using. Very often, primary part of this primary care is also referral, and so referring them to mental health, which is really common. Dermatology, ER, or urology are the most common referrals that we provide. Sometimes it's a referral, sometimes it's a resource. If it's a referral, it means like, I really need you to be seen, this is really important for you, or it's really dangerous. If it's a resource, it's more, hey, this, you should really check it out. Not that you're gonna die, but it's really good idea to check it out. Next slide, please. We'll talk about a little bit more about mental health. So with mental health, we have a screening tool for every patient who comes. It's a PHQ, so it screens for depression and anxiety. We also screen for PTSD, substance use disorder, eating disorders. The eating disorders typically is a younger population. We do have referrals as well for intensive outpatient therapies that we're able to link them to, and they can participate. And then I give them options. I ask, hey, where are you? What are you doing with your anxiety or with your depression? Do you know about counseling resources? Do you know about medications? And then either it's it's a resource or a referral, depending where are they and how critical it is. And then we offer medications, and we prescribe as well. Especially, they're really open very often for PRN. So like as needed medications like propranolol, hydroxyzine, something to take when they're really overwhelmed, a lot of anxiety or panic attack. And so options. And then if they don't want none of it, I don't believe the counseling, doesn't work for me, I tried it, I don't want any medications, they're not good for me. We talk about lifestyle and things they can do to improve, as exercise, for example, but also breathing techniques. So I have a lot of different breathing techniques that I can guide. There's links, and I just encourage them to try. And sometimes I walk them through it so they can get a little better handle on their mental health. And sometimes we have patients who are in true crisis and they have suicidal thoughts at this moment. Sometimes they have a plan, sometimes they don't. And so those require referral, and we work with a local FQHC, CMAR, and they typically screen them within 24 hours and then get them the care that they need. Next slide, please. As a prevention, I know that Abby talked a bit about it. I just wanted to mention a couple little extra things as well. We screen for vaccines. The FPO coverage that Andrea will talk about later, it covers HPV and hepatitis A and B. We also try to screen for Tdap because a lot of our men, they work in construction. And so I really want them to have their Tdap to be protected. And depending on insurance, that's the vaccine. We have free state insurance as well. So kind of educating them about that is important. We talk about testicular self-examination, especially with the younger ones or people under 30, and making sure they're familiar with their testicles, checking for them. Making testicular cancer is rare, but still it is present. And so we just encourage and talk about it, self-care. They typically come for the reason of an STI screen, so that's quite easy, but there's a lot of stigma and education that takes place. We also talk about, if appropriate, HIV PrEP and Doxy PEP. If you haven't heard of Doxy PEP, so it's a post-exposure kind of prophylaxis to get syphilis and chlamydia. So they take doxycycline within 24 to 72 hours after unprotected sex. So sometimes if people they don't have a stable partners, or they experiment, sometimes that's a really good prescription to have at the house. And then, of course, we talk about the pregnancy contraception, condoms, vasectomy, as Kai mentioned. Next, please.
Yeah, Linka, before I go to the next slide, do you want to launch our second poll? Our next slide is
Sure. Yeah.
Yeah.
Yes, we do.
Thank you.
All right. There's another poll for you guys. So thank you, Abby.
Yeah, no
How
problem.
comfortable. So we just wanted to kind of have a feel. How comfortable are you starting conversations about sexual and reproductive health with the fathers that you work with or your peers? And so feel free to choose one, and we'll give you, I don't know, 15 seconds and see what people think.
Yeah. Great. We're at like 70% have participated, so maybe one last call for an answer.
Perfect. And if we can see the results, I don't see them. I actually answered as well.
Great.
I'm part of the poll. Awesome. I'm probably the only one taking very comfortable. It's regular part. As well as for the prep. I was very comfortable talking about it every day. But that is great. It's nice to see that you guys are kind of in the middle, like somewhat comfortable, maybe a little awkward, maybe doesn't know like the next step. So awesome. So we, this slide. So next slide, please. This slide is about kind of normalizing the sexual health and conversations and little tips. I have to say that this is really, really hard to address very shortly because this is something that we can talk about for hours and days and do a lot of trainings on. But I think that there are things that probably we can kind of pull out, and one of it is stigma. So I'm sure that you guys are aware that there's a stigma in reproductive sexual health, and that's probably why it feels a little awkward at times. And feel free to put in chat, is there any other stigma you're thinking that comes in mind when you say stigma, like any other other than reproductive and sexual health? And you can totally put it in the chat if you think about like other stigma. Like another one really common is mental health, for example. Maybe no more. Okay, I have a couple more. Is abuse. A lot of people don't want to talk about abuse. It's another one. And then I think another one that comes a lot is weight and being overweight. And so those are just a few stigmas that kind of came in mind when I think about stigma. There is in reproductive sexual health, and the stigma, it could be about gender, partners, STIs. Where is sex happening? What sides? Like for some people, others are more uncomfortable. For some others, it just depends. But I think that what is important or how to address the stigma is to talk about it and talk about it well. And so, like the communication. And the communication should be non-judgmental. You should never assume, as kind of Kai said, never assume anything. You have to clarify it. You have to ask your question. Never assume anything, even if the sky is blue. You just don't assume. It could be Great Harbor and it could be gray. And then be very respectful. And there is a language that kind of comes with that as well. And with the language, I think that can be broad. So it could be a language, for example, people's first. If you guys haven't heard of people's first language, it's thinking about the person first. So instead of saying drug user, I'm going to say person who uses drugs. And so we just reverse it. So thinking about the words that we use and that they have impact and they need to be kind. When I also think about language, for me, it means also culture. Like I use a different language with the teens. I will use a different language with my 30-year-olds, and I will use a completely different language with the 50-year-old. Or if I talk with the first generation immigrants who are coming, I will use completely different language and kind of a screening tool for them as well, because that's what they need. As I kind of pointed out, to address the stigma, we need to educate, and so a lot of the first thing that comes in mind for me is herpes education, that people come, it's the worst stigma, I think, in United States. It's very stigmatized in the United States, not outside of United States. In other countries, it's just an infection. It's not a problem. And so if I'm giving the diagnosis to English-speaking person, they're crying. It's a worse diagnosis than an HIV, which is interesting. But if I'm telling that to a person who is Spanish speaking, it's not a big deal. Oh, you can give me medication to feel better? Great, bye. And they're kind of done. So doing a lot of education and about that is really important. And people are typically leaving and just feeling very, very relieved. And then things that we could all try is everyday actions. And so, for example, correcting jokes. And so if someone, I know that my kids at their school, like being gay is really bad. Like, I'm like, is that bad? Like, why are you saying it as a bad word, or picking up, or fat, right? You're fat, you're gay. Like, what does that mean? Like, what, tell me more. That is not correct. And so doing a little correction like that can go pretty far. And then some tips, how to start the conversation could be, I've just learned, I've just read, and maybe a statistics. And then what do you think about that? Um, and then a fact that's quite interesting is that people want to talk about reproductive sexual health with the providers, but the providers don't bring it up and they're not as comfortable. So we do a lot of trainings for providers to feel much more comfortable and truly bring it up during their visits. And so it could be, I've heard, the sexual reproductive health should be part of the well exam when I go and see a primary care provider. Does your primary talk about that? Like, I wonder. And so, starting just conversation like that can lead pretty far. Next slide. Do we have time?
Yeah, we're great on time.
Okay, awesome. So I have two stories, but we can also just use one if we're short. And so I wanted to give you kind of a story about a male, a men, and their health, and how talking about his penis can really, right, even save his life in a sense. And so I had a patient who is Spanish speaking, and she was coming very, very upset about HPV, was asking me questions, wanted to be vaccinated. We're asking, how does it transfer? Like, how is that possible? How do you get it? And she came several times really upset, like super upset. And she had a husband, a partner, probably for like 15 years, really long time. And then finally ask her, like, what's happening? And she's like, well, my husband has this lesion and it's not going away. And the doctor says it's HPV, but it's just there. And I'm like, well, and he's using a cream. I'm like, well, how long has it been? It's been a long time. And I'm like, well, that sounds really weird. Like, let him come to me. Let me see what's happening. And he had no insurance. So we enrolled him into FPO, which the FBO then could cover the visit to see me. And then he didn't hide anything. We always see patients alone. He said, no, I have just my wife for 15 years, nobody else. He was a smoker, a pretty heavy smoker, like a pack a day for many, many years. And then once I did an exam, it did not look like an HPV. It looked like a cancer. And I'm like, I think you have a cancer. And it could probably was caused by HPV, but really made it worse by his smoking. And so, and it was really angry and really tender. So I sent him to ER at the time, not really knowing my resources quite yet. This was a couple of years ago. And the doctor called me. He's like, what do you want me to do? I'm like, can you biopsy? Can we confirm that this is a cancer so he can get the cancer insurance and then take care of it? And he's like, I can't, but he also had kind of bacterial infection, so he was able to treat him. And then the patient came back, or there was lots of visits in between and phone calls. And we found a urology place in Olympia where they could see him. And then we had to make the referral. We had to change a couple times. The last one was that it just had to say urgent and say that he has a lesion that looks like a cancer. He was finally able to be seen. And then he was confirmed, diagnosed, and the cancer was removed. I saw his wife probably a year later, and she was very different, very happy, very relaxed. Like, the relationship was back to normal, and he was good. And I was hoping, teaching them that you need to stop smoking. Like, and I think she said he did, which was really important. Do we have more time?
Yeah, I think you can do a second story. I
Yeah.
think, yeah.
Okay. Okay. So one more case that it's really, really common. I just saw a patient this week, and this is, I would say, like really common um, male visits. Are men coming really ashamed? Oh my gosh, like I don't even want you to look. It's terrible. Like I don't know what's happening. I think my partner is cheating. Like she has to have several other partners, or I don't know what's happening down there. And then we take a peek and find out that it's just a yeast infection. It's not that their partners are cheating, they don't have an STI. It's just that they have probably, and we check, like this last patient, we checked, and his diabetes, the hemoglobin A1C, I don't know if it tells anybody, but it was 15. It was the maximum of our machine that it could do. And normally if you are above 5.7, you have prediabetes, or 6.5, I think, is diabetes. And so he had like super, super bad diabetes. And that's why he had the yeast infection. So it wasn't cheating, it wasn't no STI, it was just addressing his diabetes. And this comes quite often, especially in the summer. Men can get really sweaty, and so they just don't think about it, that they can have a yeast infection just like women, caused by diabetes or lack of aeration. And then sometimes they're a little bit like, what? I just use the fungus toe cream on my penis? Are you sure? I'm like, 100%. It's like a skin. You just put it on and it'll go away. So they're very happy and leaving, reassured that their sexual relationship is good. So that's it.
Great. Thanks so much, Linka. I just want to highlight one thing that you said because I think is so important. Having these conversations is critical, and outside the clinical health center setting, I think can be a little intimidating, as folks share, but I love that your approach was sort of just tell me more. And I think just being an active listener, and we are providing you a variety of resources at the end of today to sort of connect the next steps, right? There will be an opportunity that you don't have to retain and know all this information. We have amazing clinicians like Linka who can really get into the details of all these things, but just being able to say, do you have any questions? Do you have access to healthcare? Have you had an appointment recently? Tell me more about your fears of that, or concerns or obstacles with that. Might just open the door to kind of get people connected to have these accurate health, visits where they can get sort of really critical access to care and have these important conversations with their providers one-on-one. So with that, I think we're gonna take a 3-minute break just because we know it's a 90-minute session. So why don't we come back in 3 minutes, and we'll hear from Andrea. Thank you all. Great. Should we go ahead and get started? Andrea, I'll hand it to you.
Yeah, you bet. All right. I just want to say thank you to Kai and Lenka for giving us some insight into what happens in the clinical setting. I just appreciate this collaboration with, I am not clinical, so need our clinical partners. And always great to hear what's happening in a clinical practice in Washington State too. I have presented with Lenka in the past, and our systems are inherently and unfortunately sometimes complex. And she is part of what she talked about, the Title 10 group, and is one of many that are very creative in being able to, kind of figure out how to access those resources in terms of coverage where we might be experiencing under or uninsured folks. And so we'll talk a little bit more about that network here in our resources section. So, um, again, my name is Andrea Estes. I work for the Healthcare Authority. You can definitely move to the next slide. When we were asked, or when we were talking about what kind of content should be a part of this presentation, folks at the Fatherhood Council meeting said, we want data. So this is just a very quick snapshot of some of the data that I thought might be important to share in this meeting. And again, my lens here is really on kind of the Medicaid covered folks. And I also was able to get a little bit of information from our Title 10 folks. So Title 10 is a federal resource. It pays for services for those who are uninsured or underinsured. And for Washington State, that network is called the Sexual and Reproductive Health Program Network, and it's facilitated by folks within the Department of Health. And so it's kind of a specialty network. What you'll see here is illustrative of what we found in the data is that male participation and male utilization with across our programs has been increasing over the last few years. So utilization within the Title 10 clinics is up. The representation within our Medicaid program is over 500,000 males. Top services here are clinical services, so your typical office visit, emergency contraception, and vasectomy. And I'll talk a little bit more here about family planning only in a bit. It's a limited benefit. It sort of sits outside of more comprehensive Medicaid coverage if you are ineligible. And we've seen a dramatic increase in the participation of males within that program too. So it sounds like as we keep on talking about it, keep the promotion up. It is helpful, and hopefully it is working for folks. In terms of Medicaid coverage options, I wish it were simpler, but this is about as simple as I can get in terms of our primary coverage programs. Apple Health is what we in Washington call Medicaid. And so this is really about, I'm just going to kind of summarize or headline some eligibility criteria. In order to be eligible for more comprehensive healthcare coverage under Apple Health, the income threshold is roughly 135% of federal poverty line. So just as some context, but of course my eligibility folks don't love it when I say this, but it's more relatable. If you're working full time, the hourly rate would be under our average wage in Washington State. For after pregnancy coverage, and then what is that? What is that annual wage for Washington State now? I believe, is it around $14? It might have some variation by county, but I think it would be it's roughly around $11 an hour. So 138% of federal poverty line is quite low. After pregnancy coverage, although this doesn't apply specifically to the male or men identifying population, it could to your partner or people that you know and love. After pregnancy coverage has a higher income threshold. It goes up to 210% of federal poverty line. It also in Washington expanded from 60 days postpartum to 1 year. That is important to know. That's comprehensive coverage for 1 year after any end of pregnancy. So that could be a live birth to an elected abortion. Apple Health Expansion is our state covered comprehensive coverage for those who would be ineligible due to immigration status. So, and then family planning only is a limited benefit. And so that's only focused on family planning services. We'll talk about it here in a bit. And eligibility, the income threshold is up to 260%. And so if you are working full time, that's roughly $20 an hour. It is also a program available for those who might be seeking confidential coverage. We'll talk a little bit more. So next slide there. So I appreciate ICANN. They've put together some really helpful provider resources that we will make available to all of you after this presentation. But this is a good sort of decision guide or a decision tree for trying to find out, like, in terms of your circumstances, your demographics, your income thresholds, what type of coverage might be applicable to you or somebody that you are helping get access to healthcare coverage. All right, next slide, please. All right, so a little bit of a deep dive onto family planning only. Are there any questions in the chat that I should address, Abby? I see it blowing up a little bit.
I know. I think this is perfect timing. I think just a hint about HR1 impacts, and we're just saying the benefits of FPO is likely not going to see the same impact.
Okay, great. Okay. All right, so family planning only, we affectionately call it FPO, but just a little bit of grounding. It has been in Washington State for several decades. It has become sort of a little bit more under promoted, I would say, as we went through the ACA or the Obamacare expansion. But it still exists. We have it approved through CMS through 2030. And in Washington State, we also have what we call our state-only program. So it's the same services, but for those who don't qualify for it due to immigration status, it is paid for just through state dollars. So again, it's a limited benefit. We encourage folks to kind of think about it as a kind of a go-to program for individuals if you don't qualify for full coverage Apple Health. If you are 26 years old and under and covered by your parents' insurance, or you are a survivor of domestic violence, you can use it for confidential coverage. And again, we have the state-only program, same services, but it's for those who otherwise wouldn't qualify due to immigration status. And just as a little note, because of its history and because things change, we do want to remind folks, we used to historically have this thing called STI clinics that, or they were specialty clinics, where historically FPO was, those who were covered by FPO were only able to go to these specialty clinics, and that is not the case anymore. So in terms of Apple Health or Medicaid, if there is an enrolled Apple Health provider and they offer family planning services, FPO covered clients can go to those providers. All right, next slide, please. All right, and this might be a little repetitive, but this is what it looks like in when you go to our Healthcare Authority web pages. And we have a section on every type of program that illustrates the eligibility criteria. just to note that these dollar amounts do change. They are updated by our eligibility team at least once a year. So again, for family planning only, you have to be a Washington State resident, income at or below 260% of federal poverty line. You will see what's called, I think what do they call it? A 5% sort of set aside. So it can go up to 265%. So there's a little bit of margin in terms of income. And then again, for those who are seeking confidential coverage and might otherwise be covered by a private insurance, that is a qualifier for FPO. And there are no age or gender restrictions, but you do have to be capable of getting pregnant or impregnating someone. All right, next slide. All right, so what's included in the coverage? All right, the comprehensive preventative family planning visit, much of what I think Kai and Lenka talked to, that's what would be included in this comprehensive family planning visit, inclusive of counseling and education, risk reduction, STI testing and treatments, the permanent methods, including vasectomy, the range of FDA approved birth control methods, both prescription and over the counter, inclusive of condoms, and a select set of vaccines. And we'll talk a little bit about it, and some folks even had questions in the registration. We are really wanting to elevate this option of over-the-counter methods. They are covered. So this means for clients that if there are limitations for them to have a clinic visit, to have a prescription renewed, they can go into the pharmacy, and you do have to go to the pharmacy counter if you are covered by Medicaid. And you would be able to access, say, several boxes of condoms if you'd like. All right, next slide. All right. And so on that same note of over-the-counter methods access, Washington has a very permissive kind of policies and laws for contraception access. But that just because it's in policy doesn't mean that it's a smooth process in terms of client access. We are as kind of across agencies, from the Office of the Insurance Commissioner, who oversees all of the regulated health insurance types or payers. That's inclusive of Medicaid, but goes into employer-based insurance coverage as well. So OIC to the Department of Health, we're talking about it more. Although not as applicable, I guess, I would say to males, but one of the progestin only pill became over the counter about a year and a half ago. And this was, very new, although not new, say, in Europe, but very new to the United States. And so across our agencies, we have been polling providers and client voice to try to hear more about what barriers or facilitators might be in place to be able to receive over-the-counter contraception. We are finding that some of the pharmacy systems are just, they need to be better set up to be able to make the transactions happen. So while we move through that, we have a few tools here that we hope that will help both the provider and the consumer access their methods. And I appreciate everybody who's here today because you are providers. And we have found, for example, say public health nurses, where they have had clients who have been told that no, that is not a covered method and you can't get it here. The provider, the public health nurse, will say, hey, pharmacist, guess what we have? Look at this toolkit that the Department of Health created. And it is a walkthrough on how to process that over-the-counter contraceptive method within their system. So we have this toolkit, we have client flyers, and the Office of the Insurance Commissioner is also a go-to place for consumer advocacy. And so, for example, inclusive of Medicaid, but if it's outside of Medicaid too, and a client is charged for their method, we recommend that they keep their receipts, but also reach out to the OIC to report this issue so that they can investigate and make sure that there's a remedy provided to the consumer. All right. I just want to pause there. Is there any questions about family planning in terms of services covered, or any more questions on over-the-counter or OTC methods?
I don't see anything in the chat, but I can kind of raise it if it comes up, if that works for you.
You bet. All right, let's keep going. All right. So real quick, maybe this is familiar to some, but in terms of how to enroll, your first step, best place to start, go to WA Health Plan Finder to see what somebody might be eligible for, and they could be eligible for more comprehensive coverage. If they are not, then there is the family planning only application. There are two applications with a little bit of a difference in terms of the questions, but again, one is for those who would be qualifying under the federal program, and then one's due to immigration status that would qualify under the state-only program. They're relatively short. We are working on trying to modernize the application, and so it is something that you do have to email in. Let's go to the next slide so I can talk a little bit more about that. So the ways to submit the family planning only application, unfortunately, it is not automated online. But again, I'm hoping that is not true by, a year out from now or so. You can email it in. We do also recommend using the phone number where if somebody needs translation services, they are readily available, and FPO has a specific extension. Some of the most common questions around the application process, again, we recommend the phone number to call in. Within policy, our application customer service folks have up to 45 days to process an application. That is generally not the case, though, of how long it takes. Since I've been here, I would say the longest it has gotten up to is maybe 2 weeks for responses to come back. What Washington chooses to do is backdate that application start date to the first of the month in which you applied. If you are seeking this coverage for confidential purposes, the applicant, we recommend, is they can give whatever mailing or alternative address they want, and often clients will use their clinic as the address for communications to be sent. And if there's ever any issues or delays, you can always reach out to us directly with this family planning email. And there are two people behind that email. I am one of them. And there should be no wrong door to trying to solve a potential question or problem. All right, next slide. All right, so we will jump into some of our resources here that, yes, they will be distributed out in an email after this presentation. But right here we have two online provider network databases. So we've been talking a little bit about the SRHP, or the Sexual and Reproductive Health Program Network, those who are funded by Title X. Excellent clinic finder, and you will find that provider network across Washington. The Healthcare Authority also manages an Apple Health Provider Network tool, so the Find the Provider tool. I think it's a bit of a work in progress, but you can find those who are up to date and enrolled providers through that tool as well. And that's inclusive of pharmacies. All right, next slide. Specifically for family planning only as a benefit coverage, but also for services across Medicaid, we want consumers and clients, providers assisters, perhaps that's you all fall into that category too, um, to know what's covered. We have heard that it's, it is one thing to be able to promote insurance coverage, but some folks really have deeper questions about what types of services, what products. So we have taken some steps to try to promote that through either social media or through specific flyers. And so those resources are available. ICANN also will talk a little bit more to their tools as well that get into kind of the provider level how-tos. Something else that often comes up in this space too, and because of the sort of the prevalence of social media networks, misinformation, change in policies, the list goes on. Um, we want to make sure that consumers are receiving the right information, the best evidence-based information as well. So how the Healthcare Authority, I have a small contract with another organization called the Reproductive Health Access Project. And what you'll see come from the HCA is we will reshare what they produce called contraceptive pearls. And these are topics that often can be kind of, shrouded in stigma or just need more demystifying. And I find those pearls to be, they are reviewed by a diverse set of clinicians, and we publish them on our provider webpage as well. All of these resources we hope will help both consumers and providers get the best information into both client and provider hands in an easy and accessible way. If you ever want a bulk print of any of these materials, please reach out to us, and we would be happy to do that at no charge. All right, that is some of the HCA materials, but I'm going to hand it over to Abby to talk about ICANN's materials too.
Yeah, thanks so much, Andrea. Just a call for everyone who wants to put any questions in the chat. I can try to pick one or two left for our time remaining. But as Andrea said, we really want to try to communicate complex policies and systems to patients and providers and other community advocates. I really appreciate that a lot of what we covered today was grounded in more clinical setting. And I know that you might all be having these conversations in WIC offices or home visits or classrooms. And so really the resources that we've gathered that we'll sort of send out and share with folks is to sort of capture some of those more clinical practices or sort of recommendations or access to coverage and really have it in a simplified way for you to share with patients. I think as Andrea shared, you can also request resources from her. There's resources available in multiple languages, I think, to really communicate to a variety of community members that you serve. Some of the resources that ICANN has put into the toolkit include a little bit more about preventing the spread of STIs and HIV or vasectomy aftercare instructions, right? Like, how do we sort of just share information, make it accessible, and feel that you and your community members, folks that you're serving, clients, allies, coworkers, colleagues, partners, just feel really prepared to have these conversations and resources available to them. And with that, I know we have an evaluation that Marilyn's going to drop in the chat, and Marilyn, I'll hand it over to you. I don't see any questions, but yeah, I just will do our last slide. The deck will be shared out with folks. That has my contact information, Andrea's contact information. I think we're more than happy to think about, wow, if FPO is a program that you want your organization to really know more about, or you want an opportunity to connect with more health providers to make sure that they know about this program, we're happy to sort of talk about additional resources or trainings that we can do. So with that, Marilyn, I'll hand it to you.
Super. Well, thank you. Sorry, trying to do multiple things at once. So, gosh, what a great presentation. I just want to appreciate our presenters, Abby, Andrea, Kai, and Lenka for sharing what they know. Just a lot of really important information, I think, shared in a really accessible, informative way, and we will be sending out those resources. So thank you so much. Oh, and I meant to introduce myself. I'm Marilyn Gisser. I work at the Department of Children, Youth, and Families. and Department of Children, Youth, and Families, along with Department of Health and some other father partners have stepped in to fill in the gap as unfortunately, probably many of you know, the Fatherhood Council is not staffed at DSHS anymore. And so this was our first provider learning series without Ann Stone. She did such a great job these last few years with those, and they'll probably be looking a little bit different over the coming months and the coming year as we kind of figure out how we're doing them without Anne. I wanted to, first of all, I did want to note that I did share the link for today's evaluation, and we hope you'll fill that out. I also just wanted to let you know that we're going to continue with the learning series approximately every other month. I think for the next few, we will be highlighting different programs for fathers around the state. We've really been hearing from people that people want to know what's out there, and it's not that easy to find out what's out there. So hopefully by highlighting some different programs and sharing information around what's out there, we can help to build that knowledge. I also wanted to share that in the past, there has been a summit, and we're hoping to have another fatherhood summit this year in September. So if you're on our distribution list, you will get information about that when it's available. I think that's all I have. Just want to appreciate everyone for joining us today. And yeah, I will send out an email to everybody who's registered with the resources that you heard about, as well as some of the other links that we've shared here today. Are there any last questions? Well, if not, thank you all. Really appreciate you being here.
Likewise, Marilyn, thank you. All right. Have a great day, everyone.
Thanks all.
Appreciate your time.
Thank you.